Assalamu alaikum. I'm Dr. Nisar Akbar Khan, Assistant Professor ENT1. Our today's lecture is about hearing loss or deafness. Classification of hearing loss can be done into organic and non-organic hearing loss. Organic causes may be conductive or sensorineural. Among the sensorineural, we can further divide into sensory, that is where cochlea is affected, and neural parts. In neural, we can further classify into peripheral or central. Peripheral means when there is lesion of the eighth nerve, and central neural hearing loss when there are centrally auditory pathways involved. This is the classification. Now, conductive deafness, disease process which interferes with conduction of sound to reach cochlea. So all those diseases which interfere with conduction, they can cause conductive deafness. Lesion may affect anywhere in the conduction pathway. As you know, sound waves are cast by the cochlea, by the external ear, and from here, from pinna, sound is transferred to the external auditory canal, to the tympanic membrane. Via ossicular chain, it is transferred to the inner ear. This is the conduction pathway. So lesion may affect the external ear, tympanic membrane, middle ear, up to stapediovestibular joint, up to the oval window. Here, this is pinna, external auditory canal, tympanic membrane. These are ossicles in the middle ear, and up to this part, footplate of stapes. Any lesion which affects this much part will cause conductive deafness. Now we see the characteristics of conductive deafness. In conductive deafness, on tuning fork test, we have negative Rinne's, that is, bone conduction will be greater than air conduction. Weber will be lateralized towards the poorer ear, which means you should remember that Weber is lateralized towards the ear with conductive deafness. Absolute bone conduction test will be normal. Low frequencies are usually affected. Audiometry shows bone conduction better than air conduction with air-bone gap. I'll describe this while we see an audiogram. Greater the air-bone gap, more is the conductive loss. Loss is not more than 60 decibels and speech discrimination is good. Speech discrimination is affected when there is lesion of the inner ear. So in conductive deafness, there is nothing wrong with the speech, with understanding of speech. Here an audiogram is in front of us. This is called a pure tone audiogram. We take frequency along x-axis and hearing level in decibels or loudness along y-axis. You can see the frequency ranges from 125 Hz to 8000 or 12,000 Hz, while the hearing level goes from -10 decibels up to 120 decibels. Please remember that this 120 decibel is the maximum sound which can be heard, while the sound of 10 decibels or 15 or 20 decibels, it is the least sound, minimum sound which we can hear. In a normal person, this curve of bone conduction and the curve of air conduction both lie above 25 decibels, and there is no air-bone gap, that is, they overlap each other. Here in this patient, you can see this blue one is the curve of bone conduction, and this red curve, it is for air conduction. You can see the bone conduction falls within normal range, that is above the line of 20-25 decibels, but this air conduction, it is quite below the normal range, that is 20 or 25 decibels. It falls in the range of 40 and going up to 45 decibels. The difference between bone conduction and air conduction curve, this much part, is called air-bone gap. So in conductive deafness, bone conduction curve will remain normal because there is nothing wrong with the inner ear, while there will be loss of air conduction. And you should know that whatever the range above this graph is, It is the area, it is these are the sounds which we are unable to hear, which patient is unable to listen to. So the area below the curve is the area which patient can listen. So patient will not be able to hear these sounds of low intensity, while these loud sounds above 40 decibels, more than normal conversation speech, he will be able to listen. Etiology may be congenital or acquired. Acquired cause may lie in the external ear or middle ear. Congenital causes of conductive deafness includes meatal atresia, fixation of stapes footplate, fixation of the malleus head, ossicular discontinuity, or congenital cholesteatoma. Here in this diagram, you can see that this is a tympanic membrane, this is handle of malleus, this is lateral process of malleus, this is the attic part, this is light reflex which is found in anteroinferior quadrant. This is umbu. You can see a whitish mass behind the tympanic membrane in the anterosuperior region. This is called congenital cholesteatoma. Please remember the location of congenital cholesteatoma. It lies in the anterosuperior quadrant of the middle ear, while acquired cholesteatoma lies in the posterosuperior quadrant. Acquired causes of conductive deafness in external auditory canal. Any obstruction in the ear canal, for example, wax, foreign body, furuncle, acute inflammatory swelling, benign or malignant tumor, or atresia of ear canal. So, any inflammation, trauma, or mass within the external ear will cause conductive deafness. Here you can see it may be a polyp or a huge boil in the external auditory canal. This is a foreign body, most likely a piece of cotton in external auditory canal. Okay, it's most likely a piece of cotton which has been removed as a foreign body from external auditory canal. Cause in the middle ear, perforation of tympanic membrane. It may be traumatic or infective. Fluid in the middle ear. Infective fluid in case of acute suppurative otitis media. While secretory otitis media, there will be sterile fluid. Mass in the middle ear, benign or malignant tumors. Disruption of ossicles, for example, trauma to ossicular chain or chronic suppurative otitis media, which will erode the ossicles, cholesteatoma. Fixation of ossicles in otosclerosis, eustachian tube blockage, which happens in nasopharyngeal or throat problems. Here you can see is a diagram which shows external auditory canal and tympanic membrane. Areas of tympanic membrane show marked congestion over here in the attic part, and over here you can see an irregular perforation with rough margins, most likely a traumatic perforation of tympanic membrane. This is the mucosa of the middle ear. This is margin of the perforation and the congestion of the tympanic membrane and external auditory canal because of the effect of trauma. Here another diagram showing tympanic membrane. You can see multiple bubbles behind the tympanic membrane. This is because of secretory otitis media, where air is trapped between the fluid, and this results in bubble formation within the middle ear, a feature of secretory otitis media usually caused by adenoids. Here the tympanic membrane is retracted onto the structures of the middle ear. Because of negative pressure within the middle ear, it may be because of eustachian tube dysfunction. This white patch below the handle of malleus, this is called tympanosclerosis, sclerotic patch. Here you can see thin tympanic membranes, retracted eardrum. This is another diagram. This again shows a tympanic membrane which is highly vascular, and this most likely is a Bulge behind the tympanic membrane. It may be a mass behind the tympanic membrane in the middle ear, most likely a glomus tumor, a benign vascular tumor. Otosclerosis, we have already discussed it in your lectures. There is sclerosis of the footplate of stapes and surrounding structure, which causes fixation of the footplate and results in conductive deafness. Management of conductive deafness. In case of management, we will remove the cause, whatever the cause may be. So the cause may be wax or foreign body or infection or trauma, ossicular discontinuity. So we have to treat whatever the cause is. Removal of canal obstruction, removal of fluid from the middle ear, which is called myringotomy, may insert a grommet. Removal of mass from the middle ear, stapedectomy in case of otosclerosis, tympanoplasty or laryngoplasty if there is perforation and ossicular fixation, and hearing aid if all these fail or we are unable to perform these surgeries. Now, sensorineural hearing loss. It results from lesion of cochlea or eighth nerve or central auditory pathways. Characteristics of sensorineural hearing loss are a positive Rinne's test, that is, air conduction is better than bone conduction. Weber is lateralized to the better ear. Previously, I told you Weber is lateralized towards the ear with conductive deafness. Now you should know that Weber is lateralized towards the ear with conductive deafness and away from the ear with sensorineural hearing loss. Bone conduction reduced on Schwabach and absolute bone conduction test, more often involving high frequencies. We'll see this in audiogram. No ear-bone gap. Loss may exceed 60 decibels. Speech discrimination is poor because it involves inner ear. Whenever inner ear is involved, understanding of speech is impaired. You might have seen older people who tell that we are able to hear but we are unable to understand what other person is saying. So speech discrimination is poor in case of sensorineural hearing loss. There is difficulty in hearing in the presence of noise. Here you can see an audiogram. Again, frequency along x-axis and loudness along y-axis. The shaded black area, shaded dark area is the one which is considered normal. The graph here, air conduction and bone conduction curves both overlap each other. There is no air-bone gap. You can see no air-bone gap, and loss is more for high frequencies. Here there is a dip at 6000 Hz. Low frequencies it is normal, but loss is more for high frequencies. Etiology of sensorineural hearing loss may be congenital or acquired. Whatever the cause may be, if it's an acute onset, it may be treated. We can remove the offending agent, that is the drugs. If there is noise-induced hearing loss, patient will be need to rehabilitate his occupation and will give steroids to the patient. In case of presbycusis, hearing aid will help the patient. In case of Meniere's disease, we'll treat the symptoms of the patient, and again, hearing aid can be offered, and there are certain other maneuvers. You have already gone through it in your lectures. In acoustic neuroma, gamma knife surgery or hearing aid can be offered. Sudden hearing loss, steroids are given. Specific forms of hearing loss. Inflammation of labyrinth. It may be caused by viral, bacterial, or syphilitic. In case of viral labyrinthitis, disease is reversible. In case of bacterial labyrinthitis, it is usually irreversible. Familial progressive hearing loss. In it, there is progressive degeneration of the cochlea. It affects bilateral ears. Both ears are affected. Speech discrimination is excellent. Ototoxicity. So there are certain drugs which cause ototoxicity. These are aminoglycoside antibiotics are notorious. That is gentamicin, streptomycin, tobramycin, neomycin. Diuretics, furosemide, antimalarials, quinine, chloroquine, cytotoxic drugs. Analgesics are also notorious for causing sensorineural hearing loss. Salicylates, indomethacin. ibuprofen, alcohol, tobacco, marijuana, carbon monoxide poisoning, miscellaneous erythromycin, ampicillin, propranolol. All of these drugs may result in ototoxicity. Noise-induced hearing loss. We'll go through it in detail in our next lectures. It is caused by noise trauma. There may be sudden hearing loss and presbycusis. Hearing loss should have a high index of suspicion. Result on speech audiometry and pure tone audiometry is inconsistent. Stinger test. It's a test with the help of tuning forks. We identify that patient is malingering. Stapedial reflex or acoustic reflex will also help, and brainstem evoked response audiometry can also help us. Degree of hearing loss. You can see a graph over here. It is shaded in various colors. So the area up to normal is called normal range. Up to 20-25 decibels we can hear normally. If bone conduction, air conduction curves, they fall within 20 to 40 decibels, 25 to 40 decibels, we label it as mild degree hearing loss. That is the green area. This blue area is the area with moderate hearing loss, 40 to 55 decibels. 40 to 55 decibels, it is moderate hearing loss. 55 to 70 decibels, this area, dark blue or purple, this is called moderately severe hearing loss. 70 to 90 decibel hearing loss, this area, orange one, this is called severe hearing loss. And hearing loss beyond 90 decibels, this is called profound hearing loss. So mild hearing loss, moderate hearing loss, moderately severe, severe, and profound hearing loss. An MCQ may come in your exam from this graph.